move on to the role of skilled nursing facilities. If I had $1 for every time someone told me that skilled nursing was dead, and this goes back 25 years, I'd be a wealthy man. And Abe Gossman
define dead.
Define dead. If Abe Gossman used to start almost every speech, and I don't know if you remember this back in the 90s and 2000s, but he would start and say, the only two places in America that are constantly full are prisons and nursing homes, and no one wants to be in either one of them. And he always meant it not as a knock against nursing homes, because he owned a bunch, but he meant it as, this is a good industry. But people have constantly knocking the skilled nursing industry down. It's going to die. No one wants it. When someone comes out of a post-acute episode, do they want to go into a skilled nursing facility? Do they want to go elsewhere?
Well, they typically don't until they actually have an experience, and 85% of the people who go into skilled nursing facilities have a positive experience. So I mean, if you ask, sometimes the answer is depending on when you ask the question. I mean, if you go out on the sidewalk today and ask people what they think about skilled nursing facilities, you're still going to get, an overwhelmingly negative issue. And I think that's one of the things that the industry has to continue to work on is the brand and the image. We've worked hard and pivoted very quickly, and now seems people are using our lexicon about transitional care, because I think it better describes what we're trying to do.
That started with you guys?
I should have trademarked that. So, and there are a lot of other names that people use, but I tend to think that we ought to use more consumer-centric, words to describe what we do. And so, transitional care hospitals and transitional care centers is what we use to describe our LTACs and our skilled nursing facilities. Because that is our goal. Our whole goal is to be part of a journey. And we want that journey to be, whenever possible, home. And we think that Kindred at Home can extend, that journey and that recovery into the home setting. But, look, 25 years later, the answer is different than it was 25 years ago. I think consumers have more choices. I think consumers have more power. I think Medicare Advantage, all of the people who will influence decision-making, Medicare Advantage, case managers, you and I, are going to be looking for 21st century solutions for the care of our patients. And so that's why assisted living has been so successful. That's why we're seeing such growth in home care and home-based care models. And we're investing heavily in home-based primary care, because we think more can be done in assisted living facilities and independent living facilities and home by extending physicians and using telemedicine and medical technology to do that. That being said, we have a huge population of patients who can't afford or don't have a home in the traditional sense. And as we saw recently in a recent study, way too many seniors are basically having no contact with the outside world for weeks at a time, sitting in their apartments. And they are, with each day that they are not socially engaged, that they are not, active and in their health care and in their life, they're deteriorating. They're not maintaining quality of life and function and dignity. And so, but I think the challenge is the obsolescence of the facilities. And I think we're going to have to make major strides and investments in developing both short stay transitional care centers for the Medicare Advantage short stay rehab, but also for the chronic patients with end-stage Alzheimer's, with multiple chronic conditions, that assisted living is not an option, and home is not an option, and palliative care and hospice is what they should be getting. And my mom received care in the last 3 months of her life in a skilled nursing facility and hospice in a skilled nursing. And there was no way we were going to be able to do that even with hospice at home. And so we need to solve to, that and the kind of dignity that she got in her end of life for more seniors. And I think that's going to present a big societal challenge, but it's also going to present an opportunity for providers who are willing to think about how they reposition their SNF assets.
And we have about, let's say, 1.5 million SNF beds out there, and everything's transitioning to higher acuity. What's going to be the most important thing for their sustainability, their physical plant or their staff?
Both. I mean, so what I worry about is overbuilding of the buildings and understaffing of the staff. I mean, I think it's both. But it's also going to be different models in different communities. Because we're such a diverse country, and healthcare is defined so differently. So I think that what the product looks like, both in terms of the physical plant, and there may be some similarities, and what the staffing look like is going to have to vary. Look, the staffing is going to be a big challenge. We saw the president today talk about, moving more people into overtime classes. We've got minimum wage laws that are rightfully the right thing to do. And I certainly believe that we've got to, if we want high quality CNAs and housekeeping and service people, we're going to have to pay them a decent wage. But the Medicaid program, Medicare program are not taking that into account. So that's where the disconnect in the policy is. How are we going to pay people $11 an hour if we're reimbursing us like we want us to pay people $7 an hour?
Do you think we're ever going to have a time, and I've written about this, and you don't really hear it much, especially from the skilled providers, because obviously their license and everything is very important, but the custodial care, skilled nursing, where you kind of, I don't want to say take the care down a notch, but take the staffing, because you may not need to have the staffing that's by law, and it's all Medicaid, and basically call it, assisted living heavy, where you increase the staffing from the assisted living perspective, but then it's Medicaid funded, but
So the challenge there, look, I think we're going to have to figure out, I think we're going to have to get more creative and innovative about what the staffing looks like, what the staffing mix looks like. But here's one of the big disconnects. Many of the Medicaid patients who are chronic care patients, just go talk to a director of nursing, are as sick, if not sicker, than the short stay Medicare patients. Often sicker. The short stay
in a different way.
Well, in a different way. The short stay patients get intensive IV therapy, antibiotics, intensive rehab, but the chronic care patients are tube feeders. The chronic care patients are end-stage Alzheimer's patients. The chronic care patients have multiple chronic diseases, respiratory issues, congestive heart failure, are on 13 meds,
Which gets a little ridiculous.
Which needs to be managed better too, but I think it's an oversimplification to say we're going to be able to staff, at 2.5 hours per patient day and create, I think we have to be very careful with that, And so the cost is a staffing cost, it's a building cost, and we've got to make some societal choices about this,
And who's going to make those societal?
And who's going to
society or Washington?
Well, I mean, so long as we have middle-class America able to shield assets and not pay for long-term care, then I guess, public policymakers are going to have to deal with this issue until they change that dynamic. Until we put the responsibility back on people to pay for long-term care, I guess government's going to have to decide. Right? That's part of the structural problem.